I'd give you a series of Insta lecture on this topic, which is bleeding disorders. And today I'd particularly focus or emphasize on two hereditary platelet disorders. One is Glandmans thrombus and another is Bernard-Soullier syndrome. But before I go into details of these two topics, I'd give you a brief overview of bleeding disorders. All bleeding disorders, it could divide into basically three groups, subgroups. One group of bleeding disorders are usually caused due to some defect in the blood vessel wall. This could be due to seen in scurvy, in vitamin C deficiency. It could be seen in systemic amyloidosis, or it could be seen due to prolonged glucocorticoid therapy. And all these conditions, usually the blood vessel wall become weak and they become more vulnerable to bleed. The second group is basically a defect in the primary hemostasis, or defect associated with platelet. Now this group, the platelet associated bleeding disorder, could be again subdivided into two groups. One group could be due to less number of platelets. These are called thrombocytopenia. Less number of platelets obviously would result in bleeding because there are not adequate number of platelets to form the platelet plug to close that hole or gap. And second, it could be due to some functional platelet disorder, that platelets are okay in number, but platelets are not functioning adequately to do their job effectively. And the third group of bleeding disorder could be due to some defect in the clotting disorders or defect in secondary hemostasis. And typically in this group we see hemophilia A, hemophilia B, and hemophilia C. And obviously hemophilia A is the classic example of this disorder. Hemophilia A occurs due to factor 8 deficiency, hemophilia B due to factor 9 deficiency, is also known as Christmas disease, and hemophilia C due to factor 11 deficiency, is also known as Rosenthal syndrome. So at the very beginning I told you that all bleeding disorders could basically subdivide into three groups. Due to defect in the blood vessel wall, which leads to excessive bleeding, could be due to defect in the primary hemostasis or defect associated with platelets. Either platelets are decreased in number or platelets are functionally ineffective. And third group is due to some defect in the clotting factors, typically hemophilia, which I mentioned as a classic example. Now in this today's session, I particularly emphasize on two hereditary platelet disorders, and I will start with Glandmans thrombus. Now Glandmans thrombus, as the name suggests, the name is made with Glandman, who is a pediatrician who first described this disorder. And thrombusthenia means that thrombocyte plus asthenia. Thrombocyte means platelet, and asthenia means absence of stenosis or strength. So in this disorder, as the name suggests, you understand that the platelets are weak. And just it reminds me of myasthenia gravis also. Myasthenia name also, you get this term asthenos. Myo plus asthenia plus gravis. Myo means muscle, absence of strength, and gravis means severe. So there is a severe weakness of muscles in. Similarly, this is Glandmans thrombus. Dr. Glandman described a condition where the thrombocytes or platelets are having weakness, or they don't have adequate strength to aggregate together. So Glandmans thrombus is basically a hereditary platelet disorder where the platelets could not aggregate, could not glue together, could not join together to form that clump effectively. This is the basic problem in Glandmans thrombus. And if you look at the molecular level, at the biochemical basis, basically this is due to some defect in the glycoprotein 2b3a, also is known by a specific integrin glycoprotein alpha 2b beta 3. So this particular glycoprotein is actually required to adhere in the adhesion of two platelets. So this is suppose one platelet, this is expressing glycoprotein 2b3a, and this is another platelet expressing glycoprotein 2b3a. In between there would be a fibrinogen which would act as a sandwich material, I would say. It would be sandwiched between these two glycoprotein 2b3a. And then in between of my two fingers there is a fibrinogen, and these two platelets, with the help of this 2b3a, they would aggregate, and this way one platelet could aggregate with another, and in this way the whole platelet aggregation forms. So when your platelets, there is a defect in this glycoprotein 2b3a, which are my fingers actually, I'm trying to show. Obviously your platelets cannot aggregate together with the fibrinogen, because this glycoprotein 2b3 actually act as a fibrinogen receptor, because they help to aggregate two platelets with the fibrinogen in between. Actually, I have drawn also, which I have shown you earlier today. So suppose this one, you see that this is two platelets. This is one platelet and this is another platelet, and in between there is this rectangular thing. The red thing is the fibrinogen, and these two receptors are glycoprotein 2b3a. So if the 2b3a, these receptors are not there, obviously the platelet aggregation cannot occur, and that is the basic defect in the Glandmans thrombus. That's why this condition we described as platelets are weak. Now, Glandmans thrombus could be moderately, as classically described in the literature, moderately to severely bleeding disorder, moderate to severe. This is an uncommon disorder as such, but if it is present, it could be quite problematic for the patients. And typically, it is inherited in autosomal recessive fashion, and this is more common in those communities where there is a consanguineous marriage is common. Now, how do this patient present? Typically, their first presentation is usually seen in first year of life or within the first 5 years of life. And typical first presentation, as described, is usually with nose bleeding, epistaxis. And other forms of mucocutaneous bleeding could also occur, like gum bleeding could occur. It could present with menorrhagia, since the menarche. That could be a big problem for the patients also. And sometimes the bleeding goes on, the mucocutaneous bleeding goes on for a whole day. It could be troublesome for the patient. And often the patients, the parent of the patient, they first notice that the affected kid is having severe nose bleeding or severe epistaxis. Now, how to diagnose this disorder? Obviously, if you do the platelet count in this condition, platelet count would be normal, and platelets are also morphologically normal in Glandmans thrombus. But the key test would be to go for the platelet function test, platelet aggregatometry test, and the platelet aggregation test would be typically abnormal in this condition. And here I also like to mention that coagulation test would be normal in this condition, because there is no problem in the coagulation factors as such. And ristocetin induced platelet aggregation test, that would be also normal. But ristocetin induced platelet aggregation test is usually abnormal in its differential diagnosis, like Bernard-Soulier syndrome, or in case of the von Willebrand disease. And here I would like to tell you a brief about the ristocetin and ristocetin induced platelet aggregation test also. Ristocetin actually was introduced as an antibiotic, but it became a big flop as an antibiotic. But later they found that this flop antibiotic could be useful, because it could be used as a lab investigation test to help differentiate Bernard-Soulier syndrome and or diagnosis of the von Willebrand disease. Because this ristocetin, through some unspecified mechanism, actually they can help to aggregate the platelet, which is glycoprotein 1b receptor, with the von Willebrand factor. So in presence of this, in vitro there would be a platelet aggregation occurs. But when this glycoprotein 1b receptor is deficient, or von Willebrand factors are not there, obviously there would be deficiency. There will be no platelet aggregation. So this way they are helpful. I have discussed this in this a big topic actually. I discussed this in a different lecture. But the very important point is that this Glandmans thrombus, ristocetin induced platelet aggregation would be normal. So in a brief, what we learned about the Glandmans thrombus, that Glandmans thrombus is an inherited platelet disorder. It's inherited in the autosomal recessive fashion. It's actually could present with, sometimes it could present with severe bleeding, and the bleeding which goes on for persistent. But with adequate care, usually this problem is taken care of nicely. Their typical presentation is with epistaxis, nosebleed, which I mentioned, could be present with menorrhagia, and platelet aggregation test is typically abnormal, because the basic defect is in the platelet aggregation. Thank you very much.